much ado, I shall share my screen and we shall go into the presentation. Please confirm if my screen is visible.
Yes, doctor.
Thank
Yeah.
you. So today we will be talking about the topic complete denture, troubleshoot common complaints. So complete denture is a prosthetic modality which most of our edentulous patients opt for if not implants. So, but after delivering a complete denture, we tend to have a lot of complaints from the patient side that we need to keep recalling the patient every other month or maybe every other year. So there is a continuous follow up or recall appointments which are required for all our complete denture patients. So today I will be talking about what are the most common issues that the patients come back with, and as a dentist how can we solve those issues. So today being Vishu, a very happy Vishu to all of you, and thank you all for taking out the time to join me in today's webinar. So I would be going into the introduction. So complete denture service, it cannot be adequate unless the patients are cared for after the dentures are placed in the mouth. So in many instances, the most crucial time in the patient's perception of whether the denture is a success or a failure is the adjustment period that the patient spends with the dentist. So the dentist is solely responsible for the care of the patient throughout this adjustment period, and this occasionally requires a number of follow-up appointments. So the complete cooperation of the patient during the adjustment period is essential, and educating the patient. So the dentist must clearly explain to the patient what are the issues that can arise after a complete denture is inserted into a patient, and what are the issues that the patient would be facing during the adjustment phase, and the procedure, so that both the dentist and the patient can meticulously follow so that we alleviate these problems. So it is important that the dentist and the patient initially has a clear understanding as to the financial implications as well, because as you're all aware, there are certain troubleshoots that we come up with when you would have to redo something. So that also involves financial implications. So all these communications, if communicated well prior to the patient, I think the adjustment phase goes very smoothly. So, what are the sequelae of wearing a complete denture? So, the use of a complete denture is not trouble free. Dentures can cause side effects. If left untreated, they lead to destabilization of occlusion, loss of retention, reduced masticatory efficiency, poor aesthetics, increased ridge resorption, tissue injury. So, these issues will progress till a stage where the patient is considered prosthetically maladaptive and cannot use a denture anymore. So, interaction of the prosthesis and the oral environment has several aspects. So, the surface properties of the prosthesis may affect plaque formation. If there are any surface irregularities or microporosities that can enhance microbial colonization. Furthermore, the design of the prosthesis, so the health of the adjacent buccal mucosa, the composition of saliva, what is the salivary secretion rate, the oral hygiene practices maintained by the patient, the denture wearing habits also affect the formation of plaque. So, a prosthesis may promote infection of the underlying mucosa, caries, periodontal disease, or if the patient is having an overdenture, it can cause periodontal disease of your overdenture abutment, periimplantitis, chemical degradation, or corrosion of the prosthesis if the patient has a complete denture with a metal attachment in it. So all these disorders produced or accelerated in the oral tissue due to presence of something termed as a sequelae of wearing complete denture. So we have two types of sequelae. One is your direct sequelae and one is the indirect sequelae. So we have different authors who have classified what are the post-insertion denture problems. So according to Hartwell and Rand, they say that incompatibility with the environment surrounding oral tissues, problems related to mastication, any disharmony with functions like speech, respiration, deglutition, dissatisfaction with aesthetics, and deterioration of the soft tissue or bony support. According to Winkler, we have tissue irritation and ulceration, defective speech, inability to eat due to the rough surface of the denture to the tongue contact, faulty aesthetics. Now, according to Morstad and Peterson, there is post-insertion problems are comfort, function, aesthetics, and phonetics. According to Shari, we have two complaints. One is the common and the uncommon complaints. So these are the very most common complaints that a patient comes back to the dentist after we insert a complete denture. So they say that the denture is loose or unstable. The lower denture rises when I open my mouth. I have got sore spots. I feel like gagging. There, I feel that there is space in my upper denture. The patient cannot speak properly, so there are phonetic problems. Then they cannot chew food like before, or there is masticatory insufficiency. They say that they have loss of taste, or the denture clicks while eating or talking. Then when they swallow, they have pain. They say that they have food which gets trapped beneath the dentures, saliva under the denture, then dislodgement while they drink water, drooling at the corner of the mouth. The denture appears to be very bulky. Then the patient can have cheek, lip, or tongue biting issues, halitosis, xerostomia, excessive salivation, different type of taste that the patient experiences, TMG problems, and burning sensations. So these are a list of issues or complaints that our patient regularly comes back to us after we insert a denture. So after we insert a denture, the next step is we follow a 24-hour oral examination and treatment routine. So an appointment for 1 to 3 day adjustment should be made routinely. So patients who do not receive attention during 1 to 3 days after inserting a denture have more trouble than the patients who are cared for in the first several days after insertion of a new denture. So this is the most critical period in the denture wearing experience of a patient. So when the patient returns for the first adjustment, we know that the patient can tend to have, sore spots, or there is pain because of the denture. So we can ask them, how are you getting along with the sore mouth? So this helps our patient to describe more about their experiences and soreness if there are any. So the dentist must carefully listen to the patient, and on basis of what comments the patient gives us, we can learn approximately where to look for the trouble and how is their mental attitude towards the denture that may be developed during the course of our treatment. So, what is the routine examination procedure that we do after we insert a denture and when the patient comes in for your day 1 to day 3 of your routine examination? So, initially, before you remove the denture from the mouth, examine the occlusion of the patient. To do this, the mandible, you manually guide the patient into centric relation by stabilizing the mandibular denture with your index fingers on the buccal flanges and your thumbs under the mandible. So the patient is asked to retrude, elevate the tongue, touch the roof of the mouth at the back during closing. So some amount of manual guidance would be given by the dentist on the patient so that you simultaneously achieve a hinge movement. So you also direct the patient to open and close the lower jaw until they feel the first touch of your teeth behind. So after the first contact, the patient is directed to open and repeat this closure movement. And only at this time, you feel that there is a tooth to tooth touch, and then you ask the patient to close tightly. So if the tooth touch and slide, there it means that there is a error in your centric occlusion. So when you note that there is an error in your centric occlusion, the dentures are placed on a remount cast on the articulator and the occlusion is rechecked in the articulator. Now on the articulator, if you find the same error, it means that you have to adjust the occlusion in the patient's mouth. If there is an error in the mouth, but when you check it on the articulator, there isn't an error, it means that you have to go in for a new interocclusal record should be made. So now the mandibular remount cast is removed from the articulator and the upper cast is remounted with a new centric relation record to correct the occlusion error. Now, after the occlusion has been tested and corrected, we ask the patient where is the worst soreness, or where do they have the maximum amount of pain, and we do a thorough visual examination of the oral cavity to locate the sore spots in the oral cavity. Now, the examination, how do you start with it is you examine from the maxillary buccal vestibule, proceed around through the labial vestibule, and again to the buccal vestibule on the other side of the mouth. Also, special care should be given to observe the frena. Now, the hamular notches and the hard palate and soft palate should also be observed for signs of any abrasion. Now, the area of the coronoid process is palpated. Patient is asked whether there is any tenderness in this region. The mandibular dental arch and the associated dental structures are also systemically examined examined both visually and digitally. Now, the tissue which lines the vestibular spaces and the alveolingual sulci, particularly the mylohyoid ridge and the retromylohyoid spaces, are also observed carefully for any sore spots, as well as your sides of the tongue and the mucosal lining of the cheek also must be inspected. So as you can see in the picture here, the second picture where you can see the maxillary upper cast. So you can see when you do a thorough examination, always go from the buccal vestibule to the buccal vestibule. Take special care of the frena. Check whether there are any sore spots. Also check for the hamelar notch area, the posterior palatal seal area, if there are any sore spots. In your lower, in the mandible, always check for the labial vestibule, the buccal vestibule, the retromylohyoid region, and the alveolingual sulci if there are any sore spots that the patient has developed. Now, what are the adjustments that you can do to the occlusion in your complete denture? So, soreness may develop on the crest of the residual ridge because of pressure, which is created by heavy contacts of your opposing teeth in the same region. So, soreness may also be seen on the slope of the ridge as a result of your denture base shifting because of deflective occlusal contacts. So, whenever there is a sore spot or an ulcer that you note on the crest of the ridge or on the slope of the ridge, it is because of some premature occlusal contact. So, that needs to be corrected. So, before unnecessarily shortening or excessively relieving the denture base in that particular area, always make sure to recheck your occlusion carefully in the mouth as well as in the articulator, giving special attention to any sort of possible heavy balancing side contacts that could cause the rotation of the mandibular denture base. So, whenever you see a sore spot on the crest of the ridge or on the slopes of the ridge, please make sure that you attend to the premature contact. So such occlusal errors are almost impossible to locate in the mouth because of the movement of the denture bases in the supporting soft tissue areas. So a clinical remount and occlusal equilibration may be needed to correct such occlusal errors during follow-up visits. So small lesions on the buccal mucosa of the cheek, which is in line with the occlusal plane, indicates that the patient is biting the cheek during mastication. So this can be corrected by reducing the buccal surface of the offending mandibular teeth to create more, basically you have to create more additional horizontal overlap so that your buccal mucosa can escape through that space. So now your patient tells that my denture was very tight when I first put them in the mouth, but then they seem to loosen after several hours. So why does a patient come back to you with such kind of a complaint? So it is because that there is a error in occlusion that is happening, which can be corrected if a new interocclusal record is made. So again, what you go back and do is your dentures are remounted and the occlusion is adjusted in the articulator. So the denture becomes loose because of any deflective occlusal contacts, which cause your denture base to shift, which in turn causes distortion of the tissue in the basal seat, which leads to the sore spot. So although this problem may develop by the time of the 1 to 3 day adjustment, it is more likely to be seen later as well. What are the adjustments that can relate to in the denture base? So, irritation of the vestibular mucosa is most often caused by denture borders, which is sharp, or denture flanges, which is overextended. So, this is often seen in the hamelar notch area, mandibular retrohyaloid area, mandibular buccal shelf area, and your prominent anterior frenum. So before any adjustments are made, a heavy coating of your pressure indicating paste or a disclosing wax in the offending area with border molding is done. So you can determine whether the problem is actually overextension or whether it is a contact pressure along the bone at the flange extension. So lesions in the region of the hamelar notch should be taken very carefully. Why? Because if the irritated tissue is posterior to the notch, then that means your denture base is long and it must be shortened. However, if your sore spot is in the notch, in the hamelar notch itself, it means that the posterior palatal seal is creating too much of pressure and the inside of the tissue surface of the denture base would require to be relieved very cautiously so as that you shouldn't loosen the border seal as well. So there are two scenarios that we saw here. If you have a sore spot on the hamelar notch, there are two locations. So if the irritated tissue is posterior to the notch, your denture base should be shortened. However, if the sore spot is on the position where the hamular notch is, it means that the PPS area is creating too much of pressure. So you trim the denture tissue surface of the denture base with very extreme caution so as not to loosen the border seal. So we use the following three steps to evaluate the area with a pressure indicating paste. So one notch with adjustment, the other side notch also with adjustment, and then the posterior border length and the posterior palatal seal on the denture surface with adjustment. So use of these three steps would minimize making any error in reading how a PI, the reading what you get when you apply a pressure indicating paste on the tissue surface of your denture, and over reducing the seal of the denture basically. So the remainder of the denture border are shortened. They are rechecked again with a pressure indicating paste. Finally, your denture should always be polished before you insert it into the patient's mouth. Now, the picture that you see on the right side, you can see that we had applied a pressure indicating paste on the tissue surface of your upper denture. We had placed it in the patient's mouth. You can see that there is a pressure. You can see a pressure spot which is seen in the posterior palatal seal area. So what you do is basically give a little bit of relief in that area, make sure not to loosen the seal of the denture, and then polish and reinsert the denture. Again, before you send the patient off, you can use a pressure indicating paste, recheck whether there is uniform seating of the denture throughout and there is no pressure that is exerted by any particular area on your maxillary denture. The other thing that we spoke about was any irritated frenum. So, irritated frena and disclosing wax showing pressure in the notches would require that the notches are deepened a little slightly. So, you can see the picture on the right side, the patient's frenum after you had applied disclosing wax onto the border of the denture and done a border molding movement. You can see that there are two areas wherein the frenum needs to be widen. So only deepen those particular area. So widening of the notch may not always be necessary, and if it is done in excess, you can lose the retention of your denture as well. So please be very careful when you widen your labial frenum. The notch is deepened always with a fissure burr, and it should always be polished with a stone or a small wheel. The pressure indicating paste should be used to evaluate pressure areas on the basal surface, regardless of whether the ulceration or the sores are evident or not, because not always your patient might come back to you complaining that they have a sore spot. Maybe when you visually examine the patient, the intraoral cavity, you tend to see that there are minute pressure spots. So use a pressure indicating paste to relieve all those areas. So it should be applied and read in the same way as described during the how we insert the denture before the post-op follow-up. So when pressure areas are found, they need to be adjusted and the entire denture needs to be disclosed again so that we make sure that there are no further pressure points that are seen. Finally, you can also, the contact would be uniform throughout the denture. So you can use an indelible marking pencil over the area where the patient has an ulceration and transfer the pressure spot onto your denture and make sure that that area is relieved so that you do not have that pressure spot transferred always. So always first go in for your pressure indicating paste. To recheck, maybe you can use your indelible marking pencil. So here we can see that there in the lower arch, the picture on the upper left side, you can see that there are two pressure spots seen on the anterior part of the labial region of the mandibular arch. So you can see that on the pressure indicating paste is applied on the lower denture on the upper left side, upper right hand side picture. You can see two small areas wherein the pressure indicating paste is not there. So those are the areas which are exerting pressure on the ridge. So make sure that those areas are relieved. Similarly, you can see that there is an ulcer on the lower left side picture. You can see the upper arch has an ulcer. Wherein you can see the maxillary denture when you apply a pressure indicating paste and place it in the patient's mouth. Wherever the patient has an ulcer, that area, the paste wouldn't be there. So that's the area that requires relieving. Any excessive pressure from the mandibular buccal flange in the region of the mental foramen can cause the patient to have tingling or numbing sensation at the corner of the mouth or in the lower lip. So, why does this why does your patient come back and complain that they have numbness or tingling sensation in the lower lip or the corner of the mouth is because our denture impinges on the mental nerve, and that particularly occurs in patients who have excessive resorption because the mental foramen tends to be located more nearer to the crest of the mandibular residual ridge. So similarly, the same scenario can be anticipated for your maxillary denture as well. Why? Because your maxillary denture can exert pressure on a pronounced incisive papilla, which also creates the tingling or the numbing sensation because pressure is exerted on the nasopalatine nerve. So the patient can complain of burning or numbness in the anterior part of the maxilla. So if your patient complains of burning or numbness, it is because of a excessive pressure that is exerted either on the mental foramen region, or if it's in the case of the upper denture, it is in the incisive papilla region. So relief may be required in the maxillary denture base in those regions. And now patients may return for the initial adjustment appointment complaining that the denture is making them gag. So this problem may actually be related to the denture themselves, or it could also be psychological. So if the problem is denture related, usually the maxillary denture is the culprit. So sometimes even your mandibular denture can cause the patient to get the sensation of a gagging. So most often the gagging relates to the posterior border of your maxillary denture. So the border may be improperly extended, or the posterior border seal may be inadequate. So these are the two situations that we anticipate here. So gagging often occurs when the posterior border seal is disrupted. As the tissue distal to the vibrating line, it moves upward and downward during function. So when the vibrating line has been properly located, it is not necessarily to extend the posterior border of the maxillary denture 2 millimeter beyond this point. So if the PPS is inadequate, what you do is you take the modeling compound, add it to the posterior part of the denture, reshape your PPS area of the maxillary denture so that you alleviate this situation. And then the modeling compound area can be replaced with an acrylic resin. So the conclusion may also be a factor because of shifting of the denture bases affects your posterior palatal seal area. So if your patient comes back to you complaining of the gag, and if it is because of a maxillary denture, always anticipate that it is an issue with your posterior palatal seal area. Now, on occasion, patient will state that the maxillary denture becomes loose when they open their mouth wide to bite into a sandwich, or when they try to yawn wide, the maxillary denture gets dislodged. So, generally, this complaint indicates that the distobuccal flange of the maxillary denture is too thick, and that interferes with the normal movement of your coronoid process. So, the border of the maxillary buccal flanges should properly fill the buccal vestibule. However, the distal corner of the denture base below the border must be thin to allow freedom that is necessary for movement of your coronoid process. So always make sure your distobuccal flanges are thin, because you need to allow free movement of the coronoid process, because when in function, otherwise the denture tends to dislodge. So again, when you discuss with patients, sometimes they come back to you saying that maxillary denture dislodges when I smile, or when I do any other sort of facial expression. So this why the upper denture dislodges during facial expressions or smiling is because there is excessive thickness or height of the flange of the maxillary denture in the region of your buccal notch or distal to the notch, which causes this problem. So as the buccal frenum moves posteriorly when in function, it encroaches the border that is too thick, and the denture gets dislodged. So reduction in the width of the border, which is posterior to the buccal notch, will relieve this problem. So always make sure your distobuccal flanges are thin. The area of your buccal notch is also thin, because you need free movement of your frenums and your coronoid process. So if your denture dislodges when the patient opens the mouth, when if your denture dislodges when the patient smiles, these are the two things to be taken care of. Now, your patient always have a subsequent oral examination and treatment for your patient after you insert the denture. So, your dentures should be thoroughly inspected, and sometimes further adjustments should be done during the course of the time, not only during the 1 to 3 day um, adjustment phase, even after several weeks. During the first several weeks, your acrylic resin tends to absorb more water. So this can result in small changes in the shape and the size of the denture. So even though the alterations are very minimal, they may be sufficient to change the occlusion. So minute changes in the occlusion can create discomfort by making the denture shift or slide when in function. So soreness reported by the patient in these kind of situations is most likely always it is a complaint on the lingual side of the mandibular ridge in the region between your canine and your first premolar. So this is most likely due to deflective occlusal forces between the last molar teeth diagonally across the mouth, or often between the balancing inclines of your mandibular second molar. So always if you notice that there is an ulcer that you see on the lingual side of the mandibular ridge in a region between your canine and your premolar area, it is because that whenever you have a premature contact and you do a occlusal reduction, the denture tends to slide forward and because of occlusal deflective occlusal forces, and that's the reason why you get a sore spot on the lingual side of your mandibular ridge. Now, in most instances, the occlusal error can be observed and corrected by placement of the denture in their original remount cast on the articulator. So, however, if your denture bases have changed and they no longer fit into the remount cast, the way they did initially, whenever you were doing the process of your complete denture fabrication, you will have to make a new remount cast and a new interocclusal record. So the phasebow remount jig that you had used for your maxillary denture can be reused without making a new phasebow transfer. And after your new interocclusal records are made, you can perform selective grinding with the same procedure that was done whatever you had done at the time of denture insertion. So it may be noted that the occlusal changes would be very minimal, but the soreness that they produce is actually real and disturbing for the patient. So we as dentists should not succumb to the temptation to grind from the denture base without determining what is a real cause or the real trouble that the patient is having. So sometimes generalized irritation or soreness of the basal seat would develop, although this condition may be attributable to several factors. You can have increased vertical dimension of occlusion, maybe some nutritional or hormonal problems, or unhygienic denture. It is more likely that the issues that the patients come back to you is because of an improper occlusion. So errors in occlusion should be suspected whenever patient states that the denture is very tight when I had injected it, or the denture tend to loosen later in the day. So whenever the patient complains of issues like that, it is always because of a improper occlusion. Now, certain symptoms at an adjustment appointment suggest increased vertical dimension of occlusion. So, the patient comes back to you saying that after I have worn the new denture for several hours, my gums are hurting and the muscles of the lower part of my face seem very tired. So, your patient comes back to you with a very sad face because their muscles of mastication are very fatigued, they're very tired, they don't enjoy any part of the denture. It's overall causing them irritation. It is probably because you have a increased vertical dimension of occlusion. So when you remove the denture, the mucosa of the basal seat would exhibit a generalized irritation. So these symptoms indicate that when the patient's mandible is in the resting position, there is no sufficient space between the opposing tooth to allow the supporting structure of the residual ridge and the facial muscles involved to rest normally. So, if this is true, there are other reasons. So, sometimes creating a small amount of additional interocclusal distance would solve the problem. So, what you can do is the dentist can do this by returning the denture to the articulator, grinding the denture teeth to reduce a bit of your vertical dimension of occlusion. Aesthetics and the amount of clearance that you expect between your anterior teeth are the limiting factors in this procedure. And another 1 to 1.5 millimeter of interocclusal distance can be created. So other times it may be necessary to reset the whole of the artificial teeth either on your upper or on your lower denture as well. So the decision as to which teeth should be removed is solely based on the aesthetics that is to be achieved and your vertical dimension of the occlusion. So sometimes the worst scenarios, what you have to do is both your dentures would have to be remade. So that is the worst scenario that you anticipate in a complete denture patient. So now your patient should have a periodic recall for oral examination. So when the patients are judged to be successfully treated, and necessary adjustment appointments after denture insertions are completed, the patients are instructed to call for an appointment if they have any problems. So, patients with more difficult problems should be scheduled for appointments periodically, perhaps every 3 to 4 months. We need to recall the patient. So, when you schedule a recall appointment with a patient, what generally happens is their morale, and they it helps their morale, and they tend to eliminate seeking adjustments every other week. Otherwise, you can see your complete denture patients coming back to you every other week for an issue. So, whenever you deliver a complete denture, always make it very clear to the patient that you would have an adjustment phase that is required to attain a completely functional complete denture. So, schedule appointments after 24 hours, 1 to 3 days, and then every 3 to 4 months. So every denture wearing patient should be in your recall program, and just as any other patient is. So the dentist should not hesitate to inform a patient that occlusal corrections are required. Sometimes you'll have to reline the denture. Sometimes even a new denture should be created, and other fairly involved procedures may be necessary as a part of the whole denture insertion process. So a 12-month interval is the suggested time between recall appointments for most of the patients with complete denture. So before we jump into the conclusions, I would also like to explain a bit more about some of the other regular complaints that patients come back to us with. So sometimes your patient comes back to you saying that they're unable to speak properly. So when speech is considered, the length and form and the thickness of your lower lingual flange is very important when you consider speech. So what do you ask the patient to do? You ask the patient to read loudly. So you ask them to stress on words so that every syllable is very loud, and it is heard distinctly by another family member. So patients who have reduced neuromuscular index, they do still experience difficulty in speaking with artificial teeth, but the thing that you can do is motivate them to speak aloud. So these patients, they do better if they have a lingual flange which does not extend in between the mylohyoid ridge nor too much posterior into the retroalveolar space area. So the thinnest, the shortest, and the snuggiest lingual fit possibly helps a patient to speak better than a patient who has a thick flange, which is provided. Then another problem that most of your patients come back with is that they are not able to masticate, or there is masticatory insufficiency. So, bilateral simultaneous chewing is advised for the patient to overcome chewing insufficiency. So, you ask the patient to start with a lighter diet, something which is crisp but it is non sticky, and then shift to something, a diet which is more restrictive. If the patient comes to you with a complaint that my dentures are not retentive, usually it is the lower denture that the patient generally complains of, that does not have retention. Make sure that your lingual crescent or your sublingual fold space is properly recorded while doing your secondary impressions. The another thing that patient comes back is when they speak, the other family members complain that there is a whistling sound when they speak. So that always make sure that you go and recheck the palatal vault of your maxillary denture. So you shouldn't have a very deep maxillary palatal wall, which causes the whistling noise to be heard when the patient speaks. Sometimes a patient can also complain of ear ache. So it is not ideally an earache, it is your TMJ pain, which is caused because of any premature occlusal contact that the patient misunderstands as a earache. Similarly, there is difficulty in swallowing. So, difficulty in swallowing basically comes when the patient has some mucosal irritation at the posterior limit of either your upper or your lower denture. Or it could also be because there is a increased vertical dimension that is given in your complete denture, or because of reduced salivary flow. So, in these situations, if the patient has you always encourage the patient to keep the oral cavity moist and drink more amount of water. If it is a scenario that is occurring because of increased vertical dimension, always make sure to remount your cast. Sometimes the patient also comes back saying that there is food which is getting lodged beneath my denture. So, provided that you have attained a proper peripheral seal and still the denture keeps going beneath the denture, We need to ask the patient to take some time to get accustomed to getting a proper seal with his cheeks, with his tongue, and with his lips, so that the food does not go into beneath the denture. Make sure that the proper peripheral seal is attained before we advise the patient to practice getting a proper seal with the tongue, cheek, and the lips. Sometimes the patient comes saying that when I sneeze, my the denture gets dislodged. So when you sneeze, what happens? There is a large amount of air inflow which is there in the mouth. So naturally, your upper denture gets dislodged. So the only thing that you can advise your patient is sneeze with your nose and mouth closed with a handkerchief, because when you sneeze, there is a large amount of air inflow which is causing the dislodgement of your denture. Then the patient can also come back to you saying that my denture is getting dislodged when I take some fluids or when I take water. So this is a very initial difficulty that most of our patients anticipate. But provided that you have achieved a proper seal for your upper and your lower denture, this issue shouldn't be repeating, maybe in your 3 to 4 months of your recall appointments. Another common thing is that patients says that they have drooling corners of the mouth. So why do the patient complain of drooling corners of the mouth is because your vertical dimension of occlusion is low. So in those cases, please make sure to do a remounting and correct the vertical dimension. If you say if you are confident that the vertical dimension is correct, then always stick in the labial flange of your lower denture in the area of the modulus region. So this can eliminate the issue that we have with drooling of the corners of the mouth. Another complaint that patient can tell you is they have cheek, lip, and tongue biting. So why does the patient tend to bite cheek, lips, and tongue? Is because there is a lack of horizontal overlap in the posterior occlusion. So in your premolar and your molar teeth area, when they tend to occlude edge to edge with teeth opposing, so what happens generally is when the patient closes the mouth or when in function, the cheek tends to get caught in between the teeth. So when you do your teeth setting, always make sure that the teeth is set on the ridge and the flanges are located buccal to the teeth, so that there is no cheek biting or the cheek has adequate space to get escaped. So there is another reason why you can also have cheek or lip biting is because of reduced vertical dimension, which causes the cheek to get trapped in between your teeth. So these are some of the very common complaints that patients come back to us with, and the possible reasons have been mentioned. So concluding today's topic, a patient who returns for post insertion treatment has been traumatized generally by a denture border, which usually exaggerates their pain. So they tend to indicate areas without soreness, or it could be a non specific reason as well. So, we as doctors, we shouldn't be too eager to make adjustments or to calm or placate such patients, but adjustments should only be done in the denture when your clinical reasons for them are very evident and areas of involvement can be related to the cause of the problem. So that is it from my end. So if we have any questions, we can take them.
Dr. Lano, please unmute.
Okay. Hope this webinar has helped to those who have joined. These kind of tips will help us for our day-to-day practice. If you have any doubts, feel free to ask Dr. Sonu. She will give you the answer. You can feel free to message if you have any doubts. Okay, I think you have understood the topic.
ലാനു, നമ്മുടെ ഈ ക്ലാസ് നമ്മൾ യൂട്യൂബിൽ അപ്ലോഡ് ചെയ്യുന്നുണ്ടോ?
ചെയ്യുന്നുണ്ട്.
ഓക്കെ, അപ്പൊ അതിന്റെ ലിങ്ക് കൂടെ ഒന്ന് നമ്മുടെ മെയിൻ ഗ്രൂപ്പിനകത്ത് ഒന്ന് ഇട്ടേക്കണേ, അഥവാ കംപ്ലീറ്റ് കേൾക്കാൻ പറ്റാത്തവർക്ക്.
ആയിക്കോട്ടെ.
അത് ഓൾറെഡി ലൈവ് പോകുന്നുണ്ട്, യൂട്യൂബിൽ ലൈവ്.